Hello and welcome to our third series of our series of 6. Today we're talking about hot flashes, night sweats, vaginal dryness, hormonal and non-hormonal methods to manage your symptoms and to take care of you. We are so glad you're here. And first, I'd like to introduce you to our organization, Healthy Women. At Healthy Women, we are committed to creating and disseminating evidence-based clinical health information for women 35 to 64. And for the past 30 years, we've been taking care of you. We developed this roundtable to answer your questions on menopause and to bring you the information you can use. And before we begin, I'd like to thank our sponsors, Astellas and Genev, for their investment in women and women's health. Today, we're going to discuss vasomotor symptoms, are also known as hot flashes. Some women have 1 or 2 here and there, and other women have multiple hot flashes throughout the day. We also hear women waking up soaked and wet from night sweats. And if that's not enough, let's throw in vaginal dryness, something that so many of us are experiencing, but not talking about it. So that's the bad news. The good news is there's options. There's new treatment options. There's options that are available, both prescription and over-the-counter, that can help you. And to help us begin our conversation, I'd like to introduce someone that I have admired for a long time, Anne Fullenwider, former editor of Marie Claire magazine, one of my favorite magazines. And now she's in women's health, and she's a women's health entrepreneur. We are so excited to hear from Anne and her perspectives to this conversation. So now I'd like to turn it over to Anne.
Hi, everyone. Thank you. And thank you, Beth. And thank you to Healthy Women for having me today. Welcome to all of you to session 3 of Healthy Women's No Pause in Menopause Roundtable. Just as Beth said, today's session, we're going to focus on everyone's favorite topics: hot flashes, vaginal dryness, night sweats. The official titles of which are Vasomotor Symptoms and Genitourinary Syndrome of Menopause. That's VSM and GSM. In other words, we've got a lot to cover. I'm really excited to be here today and to lead this conversation between 2 experts in these fields. I'm going to introduce you to them, and they've told me that I can keep these intros short, but they've both done so much, and I'm going to add a little bit of their accomplishments. Dr. Sheryl Kingsberg is the chief of the Division of Behavioral Medicine at McDonald Women's Hospital, University Hospitals Cleveland Medical Center, and professor in reproductive biology and psychiatry at Case Western Reserve University. I told them there were a few tongue twisters in here. Her areas of clinical specialization include sexual medicine, female sexual disorders, menopause, pregnancy, and postpartum mood disorders, and the psychological aspects of infertility. Dr. Kingsberg's primary research interests are in treatments for female sexual disorders and in GSM. Hi, Sheryl. Can't wait to talk to you soon. Dr. Lisa Larkin is a women's health internist, a menopause and sexual medicine expert, a physician and educator, an author, an entrepreneur, a women's health consumer advocate, and a breast cancer survivor. She has been previously she was the Associate Professor and Division Director of Midlife Women's Health and Primary Care in the Department of OBGYN at the University of Cincinnati College of Medicine and Director of the UC Health Women's Center. And she is now the founder and CEO of Ms. Medicine, a national healthcare organization dedicated to advancing evidence-based women's primary health care. Hello, Lisa. I'm so glad you guys are here because I have been asking questions about all of these topics for the last 1.5 years now. But before we get into sort of the meat of this, I'd like to ask you, as these sessions have always started, this is our 3rd one, to just sort of introduce us with a 30 to 60 second anecdote or thought about your own personal menopause journey. Lisa, would you like to start?
Sure. Well, first of all, thank you so much for having me. Healthy Women is an incredible organization, and it's really an honor to participate in this roundtable today. So my short story. So I've been a women's health internist for a long time. I'm old now, 30 years, let's say. But things really changed for me when I became a breast cancer patient and now breast cancer survivor. And when I lecture now, I say I am living my patient population. So I am a chemotherapy-induced menopausal woman with all of the symptoms that we're going to talk about today, and can completely relate to my patients now as I'm treating them in a much more personal way than I did prior to my own breast cancer.
Thank you, Lisa. Cheryl, do you have a personal story to share with us?
Of course. So, and I also want to thank Healthy Women for allowing me to participate. It's really an honor, and I'm so glad that you've included GSM and vasomotor symptoms today. So my story is when I first started in this field, I was 30 years old, 1991. I got my first and only job working in the Department of OBGYN. And the chairman of the department was Wolf Udian, who founded the North American Menopause Society. So it was kind of expected that I would do research and clinical work in menopause. And I thought, what an interesting topic and what an interesting population, those women who are in that 45 to 64-year-old category when I was 30 in that demographic, which was like the 20 to 30. And 30 years later, I am now it. So same as Dr. Larkin there, all of a sudden it has become me, and I am very honored to be in that population now and glad that we have done some research, not enough, but some.
Thank you so much. And that's why we're here today, to really keep this conversation and amplify it and talk about it with women who need to hear this information. We have lots of questions. We will get to the audience questions at the end of the session, but first, really, we kind of have an easy, from a moderator's point of view, task, because we got VSM and GSM, we've got two experts. I think we'll attack them sort of parallel ways. We're first going to talk about the definition, what is this exactly, and how common is it of each area. And second is the misunderstandings that are out there, not just in the patient's minds, but maybe the doctor's minds or the market's minds as well. And third is the treatments. What are the best treatments? What are the strongest treatments? Maybe if there are any OTC treatments as well that we can, over-the-counter treatments that we can start with, and misunderstandings about the treatments as well. So Lisa, could you start us off? What really is the definition of vasomotor symptoms? What's happening in the body when these occur, and how common are they?
Right, so let me set the stage by menopause definition. So that is no menstrual bleeding for 12 months. And in the United States, the average age is 51. The most common symptom for women going through this menopause transition is vasomotor symptoms, as you talk about. And the vast majority of women do have vasomotor symptoms, although some have very mild, almost non-existent, and others have very severe vasomotor symptoms. They typically start right before, a year or two before that final menstrual period, and in the majority of women will start to abate 5 to 7 years after that final menstrual period, although a reasonable percentage of women have persistent lifetime hot flashes. And really what they are is temperature dysregulation, is the way that you describe it. And as a woman who experiences it, I can tell you it is a dramatic sensation of heat that kind of ascends to your face. Before I was on my non-hormonal option, which we'll talk about in this program, I would sweat dramatically. And so when you see cartoons or hear your friends are sticking their head in the freezer, that's a very common reaction to this very significant event. And it's very, very common. The one thing I want to point out is it's not really just a lifestyle symptom. What we're now learning is that there's a lot of impact of vasomotor symptoms on sleep, which may translate to mood, which Dr. Kingsberg can talk about, but also in association with cardiovascular disease, which we really need to understand better.
Thank you. So, and how would you say, what do you know, a percentage of the population who will experience hot flashes?
70 to 80% of women will experience them, right? So a large majority. And I always say, I do have the occasional patient in my practice who doesn't have any. And I say, aren't you the lucky one? You've transitioned through with no symptoms, and that type of patient is in the minority, or woman is in the minority.
Okay, already so many questions. And I want to remind or tell you guys in the audience that please feel free to put your questions into the Q&A. It's the Q&A section, right? Not the chat section. Yes, so please continue to sort of type those in as you go, and we'll address them a little bit later on. Cheryl, can you define for us what exactly GSM is and what sort of is going on in the body, and how common those symptoms are?
So first of all, genitourinary syndrome of menopause, which is a mouthful, and thank you, Anne, for making sure everybody calls it GSM, is a relatively new term. We coined it in 2014, actually, because for three reasons. One is calling it vulvovaginal atrophy, which was its old term, was not accurate because GSM reflects the changes in the whole urogenital area, which is the vulva, which is the outside, your labia majora, labia minora, the vagina, and the urethra and the bladder, because a lot of women think, oh, it's just the vagina, but it's that whole area. So GSM reflects an accurate area coverage. Secondly, most women don't like to think about their vagina or their whole urogenital areas as atrophying, so that seemed pejorative. And third, a lot of times you can't say vagina on television. And so to be able to get the message out to women that this is common and not be able to say vagina, there have been many programs I've been on where they said, could you avoid saying the word vagina? That we changed the term. So it is now GSM. It is very common, affecting at least 50, if not more like 80% of women. Now here's what's different. Whereas hot flashes often start before actual menopause, that 12-month period after your last menstrual period, the signs and symptoms of GSM, which are due to the loss of estrogen in the urogenital tract. So when we think about hot flash and night sweats, we think about that loss of hormones, but it also has a great impact, and we have estrogen and other hormones in our urogenital tract. So the loss of that starts to have an impact a little after menopause starts. So if your average age is 51, you may not see those symptoms until a few years after. And so women don't know that it's related to menopause and their change in hormones. So we all know, everybody, even if you don't have a hot flash, knows that hot flashes are the signs of menopause. But most women don't know that those changes of GSM are related to menopause. So they don't know that they should and could be treating it that way. And they may be experiencing dryness, which is we're talking about signs and symptoms. Signs and symptoms would be vaginal dryness, the narrowing of the vagina, the urogenital tract, the thinning of the labia. If you actually looked in a mirror and saw your outer and inner lips kind of changing and feeling smaller, loss of pubic hair, all those changes are due to the loss of estrogen. And one of the big symptoms is pain with sexual activity. And way too many women have learned to live with it. They think, oh, this is just aging. This is what's supposed to happen. They don't know it's menopause related and we can treat it. So 50 to 80%. Here's the other thing, unlike hot flashes and night sweats, which for most women will eventually go away, this is chronic and progressive. It will not get better once you sort of pass through menopause. It only gets worse without treatment.
I think it's so interesting in the research I've done in the last year as a consumer and a former media person to think about, and you both already have talked about all the misunderstandings out there and how little women really know or even, are told about what's going on in their own bodies. And this is, I think, the real goal today is to clear up as many of those as we can. Lisa, what do you think is the biggest or are the biggest misunderstandings about hot flashes, vasomotor symptoms? And I know that we'll get right into treatment. So let's go there.
So again, I think I said already that, vasomotor symptoms are not necessarily benign. I think the other big misunderstanding is that women just have to suffer with them in silence. And there's a lot of reasons that we know that many women, most women, don't get appropriately treated for their vasomotor symptoms. And there's lots of reasons for that. But one of the big ones that continues to exist is really this negative opinion about hormone therapy. And if there's one message that I'd love to get through today, it's that hormone therapy is not all bad, even though that's what you may be reading and you may be hearing. And that really comes from the Women's Health Initiative data that was published in 2002 and 2004. And really that did damage to kind of the public perception of hormone therapy in a way that has just not changed, even though we have learned so much since that very, very, very important study in our understanding of hormone therapy. So even though it's almost 20 years since that was released and we know so much more now, that message for women is still out there that hormone therapy is scary and bad and you should never take it. And that has led to a lot of avoidance behavior. The other problem with the misunderstanding of the data from the Women's Health Initiative is that doctors still don't understand the data as we understand it now, particularly primary care providers who really, I can tell you, I was practicing at the time the WHI came out because I'm old, right? So I had 10, 12 years of practice already when the feeling was that hormone therapy was really good for most women and we should have them on. And that was based on data that we had then, Nurses Health Study and others. And I can tell you that in 2002, when the WHI data came out, basically primary care providers said, oh my gosh, that data looks terrifying. No women should take hormones. And that has persisted. And so clinicians really don't, in general, unless you're practicing in this space, have an understanding of the data the way that we see it now and what the problem with the WHI data was when it came out, and largely that it was enrolling lots of women who were old and remote from menopause, not the typical patient population that we're talking about now, who's a 50-year-old woman with hot flashes. And because of that misinformation or messaging still about hormone therapy is bad, patients avoid it, doctors don't prescribe it, and women are left untreated and suffering, and it's not just a lifestyle condition.
Okay, so much to unpack there. First of all, is there a population for which hormone treatment is not the right decision?
Well, so sure, it's not for everyone, but we know that even very appropriate candidates are not being even offered treatment or having a discussion about it. Because again, the messaging from the provider often that they see is they'll get better, try some over-the-counter supplements, they get better, I'm not comfortable with hormone therapy, I'm afraid it causes breast cancer, clots, you can't take it. But yes, there are certainly people who are not good candidates. I'm one of them, right? So I have estrogen receptor positive breast cancer. I am not a candidate for hormone therapy. So it's not for everyone, but certainly we know that it is appropriate for many more women who are not actually receiving it.
And is that, would you say most women? I mean, I guess this is just it's just so hard to get to the bottom of it, right? If you Dr. Google, even some women's health care, primary care physicians, people they're speaking to get this information, when they don't have the most up-to-date science and understanding of the treatments, this, I mean, I can tell you, like, as someone who's been looking for it for a year, it's really hard to get the right information, right? So can you just sort of clear it up for us right now? I know it's complex, but it can't be, it seems like it's been presented as way more complex than it really is. Can most women take hormone replacement therapy?
So I would tell you, yes, the answer is most women can. And let me talk to you a little bit about how we're doing it now and what we understand the data now compared to how the data was presented and the pitfalls of the Women's Health Initiative data that came out. So a typical 51-year-old woman who is having miserable hot flashes, hormone therapy we know is going to be the most effective therapy. We know that hands down, it works better than non-hormonal options. And in a healthy woman who is not a smoker, doesn't have unusual cardiovascular risk, has not had a prior clot, has not had a prior stroke, who is not at substantially elevated breast cancer risk for a reason, family history, genetic mutation carrier, and who is symptomatic, that patient, if a healthy 51-year-old, average risk of breast cancer, non-smoker, is fit and active and healthy, is an excellent candidate for hormone therapy. The other thing we've really learned is that there's differences in oral versus transdermal hormones and in dosing. And so we're doing things a lot differently now than we did when the WHI came out. And, again, most women really are excellent candidates for hormone therapy. Certainly not everybody.
Okay, there's so many more questions, and we're getting some questions from the audience as well about who and who is not a candidate. There's a question that we'll ask a little bit later. I see someone was asking about diabetes, and we'll get there, I promise. But you bring up vaginal estrogen, topical estrogen, which I know is one of the treatments, Sheryl, for GSM. Can you first, Sheryl, talk, let's back up a minute and talk about some of the most common misunderstandings about GSM, both in women who may be experiencing it and also in the treatments or what's out there. I think that was enough of a big question, right, Sheryl?
Sure. So most women, as I mentioned before, don't really get that it's related to the loss of hormones in their urogenital tract. They don't get that maybe some of the fact that they're having frequent urinary symptoms like UTIs or a little bit of leakage may actually be related to GSM. And so they're, seeking treatments when simple treatments for GSM could, solve their problem. They're also experiencing a lot of pain with sexual activity. And again, women just assume that they're supposed to learn to live with it. Here's another, big misconception is from clinicians who think if my patient, who of course knows I can talk about anything, is not asking me about symptoms, then she doesn't have symptoms, so I don't have to address it. So even the best of clinicians is not probably going to ask, are you having any symptoms of GSM? They don't certainly ask enough about sexual activity, much less pain with sexual activity or dryness. So I think that's a big mistake on the clinician's part. It's kind of invisible. You can see a hot flash, but you may not see GSM. In terms of treatments, first of all, if you think about, it used to be, let's avoid hormones. Again, thank you, WHI. Even local hormone. The most, it's hormones including estrogen, DHEA, right, using them locally has almost no, if any, systemic absorption. So even for those women that Dr. Larkin was talking about who are not candidates for systemic hormones, whole different ballgame here. And most of them, if not all, even cancer survivors, and oncologists are finally catching on to this because their patient population often suffers, are candidates for local hormone therapy. And that comes in pills, either a little white little vaginal pill or a capsule or creams or a ring, all of which can provide local non-systemic hormones to the urogenital tract. Really, really helpful. There's some data that laser treatments can be effective. We don't have the double-blind placebo-controlled trials for those, but we certainly do for local hormones. But they have to take them consistently. Too many women will say, okay, I feel better, I don't have to take it anymore. And guess what happens? It will come back. So they need to take it lifelong, and it can really help. Lubricants during sexual activity, let me explain also the terminology. Lubricants are short-term things like Astroglide or there's a million of them, Silk, Pure, Pink, there's millions of them over the counter used during sexual activity, can help with the dryness that many women, even premenopausally, will experience during sexual activity. Moisturizers are just like what we use for our face. We put on a cream on our face to keep dry skin moisturized, and that we can use to, again, help with some of the dryness. Those will be helpful, but they don't address the underlying tissue. What happens with the loss of hormones in your vagina is that there are three layers of cells, and the superficial cells are the cells that we lose with that loss of estrogen, and those are the ones that are thick, pleated, and provide lubrication and sort of buoyancy. And without that, your vagina starts to look like a desert and very thin and dry, and it hurts. And I will show women a picture of a well-estrogenized vagina and one that is not, and they'll say, oh, no wonder it hurts like heck to have any sexual activity. And so we have safe and effective treatments. And so back to Dr. Larkin's point about the misperceptions, local hormones, very safe, even for breast cancer survivors.
So interesting. I mean, really such a great explanation. I noticed earlier you said 50 to 80%, but most probably 80% of women. Is that related to the difficulty in bringing it up in the doctor's office, or people are embarrassed, or doctors aren't asking? That's
Yes, they don't know it's associated with menopause, and clinicians are not asking. Think about a younger clinician thinking, well, my mother doesn't have sex, I don't have to ask this 50, 60-year-old woman about her sexuality. So they're not asking. And what we know from the data is that of these 50 to 80% of women, and let me tell you, there are about 64 million postmenopausal women in the US today, about 7% are on a prescription local hormone therapy. 7%. What is everybody else doing? They're not, because clinicians are not asking, they're not getting treated, and women are still, we cannot talk about a psychologist, we cannot get that fear of hormones out of our head. It has entered into our culture, and it's hard to change that, even for local therapy.
I still want to stay on hormones for a few more minutes. I know we also are going to talk about non-hormonal treatments. And Lisa, I'm specifically interested in what you're doing and what breast cancer survivors who have that risk factor that you have and what they can do. But first, I want to talk again about the benefits. What are the benefits of hormonal therapy in terms of beyond the sort of the immediate symptoms of menopause? What are the long-term risks and benefits of hormonal treatment?
Right.
Lisa.
Right. So again, a patient population of a 50-year-old starting hormones is very different than what we learned from the WHI about an older woman, a 65 or a 70-year-old woman starting hormones. And what did we see, and what's the difference, and how do we understand that? Well, it's something called the timing hypothesis, which is that estrogen has really differing effects in younger women who don't have established vascular disease compared to older women who already have some degree of established vascular disease. And so there's a different effect of estrogen in those patient populations. And so the data in terms of outcomes that we're interested in terms of cardiovascular disease, stroke, mortality, right? How long are women living? Dementia is the other big one, right? Looking at the data in an older population gives us different results. When we subgroup the data and we really try to look at just the 50 to 59-year-olds, the data looks really different. And so what do we know about in estrogen in those situations? Well, if you look at the package insert from any estrogen containing product now, including vaginal estrogen, which I believe is really a disservice to women because the package insert is terrifying. When you look at it, it says it causes breast cancer and it causes heart disease and it causes dementia and it causes stroke and clotting, right? Who would ever take this medication, right? So it really scares women, and that is really directly from the WHI data. But what do we really know? Estrogen has positive effects in women who take it when they are younger, right? This is in terms of all kinds of things. Lipid profile, for example. Sorry.
No worries. I think it's probably some of the audience questions coming through because I've got a whole bunch piling up here. So just decided to go the direct route.
Sorry. Sorry, I don't know how to shut that off my computer. No. How the screen came off now. So I'm sorry.
Well,
so
we can see you.
Okay.
If you start taking hormones between the ages of 50 and 59,
impact in terms of cardiovascular prevention and improved life expectancy or decreased mortality is completely different than what we see in the older population where there's risks. And so, and again, we can talk about sexual health and bone health from treating the hot flashes, sleep, mood. There's all kinds of benefits of hormone therapy, again, in the younger patient population.
And when you say the younger patient population, you mean people who start taking it in that window?
Correct. So in general, and again, we would not automatically prescribe hormone therapy for a woman who has absolutely no symptoms, right? Because we are not using hormone therapy now for disease prevention. But in a symptomatic woman who is typically now we use within 10 years of menopause and is healthy, that is a woman who we think the benefit outweighs the small risks. And I can talk specifically about what I talk with patients about in terms of the whole breast cancer discussion, because that's different than really the cardiovascular discussion.
Okay, so explain that, because as a breast cancer survivor, you mentioned that you are not taking hormonals for your menopause symptoms. So what are you taking, or what, and how do you talk to your patients about that?
So I recently have said I had chemotherapy, very abrupt induced menopause, and typically we see that symptoms can be very severe. It's the abrupt loss of estrogen, and I was not even perimenopausal really at the time of my diagnosis, and so my symptoms were very, very severe and abrupt. And you add to that now that I am on long-term anti-estrogen therapy, right, and my hot flashes are miserable. So I am someone who's actually tried all kinds of the, what we call non-hormonal options. Because my tumor was estrogen receptor positive, I am clearly not a candidate, and I'm on anti-estrogen therapy. And there's lots of therapies that work. The problem is they don't work nearly as well as estrogen, and they all have side effects of varying degrees. So we use some of the antidepressants. And of course, one of the side effects, most common side effects of the antidepressants can be sexual dysfunction, which menopausal women are often having. So we use something called gabapentin, which can be effective as well, but it can be sedating. At higher doses, it can be associated with weight gain. So that's not necessarily all that perfect. And we know that if we compare them to the effectiveness of hormones, which really can be 90–95%, placebo effect, we see at about 30%. These non-hormonal options are in the 50–60% range in terms of decreasing frequency and severity. There's a more recent one, and the one that I'm actually on, and if you can tell, I have a little bit of a dry mouth, is oxybutynin. But there's side effects with that. So it's an anticholinergic medication. It's FDA approved for overactive bladder, but dry mouth and constipation are some of the side effects. And there is some data about concerns about dementia with that, with long-term use. And so all of these non-hormonals that we have available right now, have some effectiveness, and I have tried to stop mine multiple times, and I'm frankly miserable. So whatever side effects I have, I really tolerate. But the good news is there's some really exciting research and science going on in the space right now, and some really exciting new medications coming up the pipeline that I hope will be available in the next year or 2 or 3. Because again, I can tell you, in the patient population who cannot take hormones, all of the other medications available help, but they're not perfect.
Can I jump in? Because
yes,
I do think that there are some exciting treatments coming down the pipeline, and some were just presented actually at the North American Menopause Society annual meeting, which was virtual as well. These are in the brain. There's brain chemistry that affects hot flashes. So we're now researching these kisspeptins and neurokine brain chemistry and TRPM8. There are various different chemicals that we're looking at that affect the temperature regulation in the body. Because when we think about what causes a hot flash, it is your body signaling incorrectly that it needs to, it's either feeling too hot or too cold. There's this range, and with menopause, it gets narrowed. And so when it kind of gets a signal that, it's too hot or too cold, usually, what happens with the hot flash is that there is blood that surges to the periphery of your body to make you sweat, to get chilled, to cool the body down, or if it's too, which is what a hot flash is, too hot, and then you meet that range again. So these new chemicals are being addressed that are non-hormonal that will affect that range, and it's very exciting. We're finally sort of looking at all kinds of things, because it's not a one-size-fits-all. Hormones really have been given a terrible rap and are very effective, and they are the first-line treatment, except for the population that Dr. Larkin would talk about. But we need more. We need more options, and they are there.
Fascinating. I can't wait for all that science to come to light and for us to know more about these new things coming down the pike. Do either of you want to speak? And I think you both can. So maybe we'll start with Lisa. About what compounded and bioidentical mean and their safety and what that means in the treatment of menopausal symptoms.
Right. So this is an area that everybody on this call probably knows I could talk about for hours and hours and hours and feel very passionate about, because there's, again, back to your point, there's a lot of misinformation out there. And if our goal, Healthy Women's goal, is to raise the standard of care of women, education about evidence-based medicine is so critical. And this is really, again, another one of the pitfalls I didn't mention yet about what happened with the Women's Health Initiative data and how that came out, and this sudden, complete fear of hormones and change in prescribing patterns. And women fell into this crevasse of nowhere to turn. They were symptomatic after the WHI came out. No one was talking to them. No one would prescribe hormones. Women were suffering. The data was confusing. And what developed was a very significant new kind of culture of hormones called bioidentical compounded hormones, which is the growth of this has just been exponential over the last 18 years in women who aren't getting appropriate care in the traditional setting, have now found their way into clinics and situations where they're getting hormones, but compounded and bioidentical hormones has come up as a term that has been marketed as products and estrogen and hormones that are safer, right? That don't have all these pitfalls of these bad FDA approved ones. And there's really, really no science to back that up at all, and no data to say that we need to go this compounded route or that these are safer. And in fact, what I see in practice all the time is supraphysiologic doses of hormones that these women have been getting for a long period of time, and side effects related to those things, and of course risk. And so women are being misled, don't have adequate information to make a good decision, in my opinion. Now, the exciting thing is that as again, things have evolved and there's been more research and science since the WHI, we now have FDA approved bioidentical hormones, right? So the term for women that is misleading, right? So when women often hear bioidentical hormones, it's really, they're talking about compounded hormones. What bioidentical means is that it is hormone preparations that are the same as the type of hormones that your body makes. And the truth is, it's not a distinction between compounded and FDA approved, because we have FDA approved bioidentical estrogen and progesterone. So when women come in and say, well, I'm afraid of estrogen, I don't want to take hormones, I've only heard that those bioidentical hormones are correct, I can still prescribe them in a bioidentical form. That's different than these compounded hormones that women are often being misled are safer and have no risk, and it's just not based in good science.
Thank you. Again, I have so many of my own questions, but I think I should, there's so many great ones coming in from the audience that I want to address some of them. Can hot flashes start, this I guess is for Lisa, sort of occur for a number of years and then stop for a number of years and then resume for a number of years?
Right, so absolutely. So as the ovaries are failing, right? So, and this can start in, this period of time we call the perimenopause. So, fertility starts to decline and ovarian hormone production starts to be inconsistent and change. And so women definitely will come in noticing changes in their menstrual cycle, changes in their bleeding pattern, but also new symptoms, more bloating, more PMS, sleep disturbance, and intermittent hot flashes can really start. And lots of times women will say, I don't know, I had a couple weeks of them, or I had a couple days of them right around my period, and then they've been better. And so that definitely correlates with inconsistent hormone production, particularly estrogen. And so women, as they get later in the menopause transition, later perimenopause, will often have periods of time where their estradiol level is low, and that will be associated when they have hot flashes. Now, for reasons that are different in every woman, but women can have symptoms and irregular periods for 18 months, 2 years, and then they may go through a period where they have very regular cycles again and things seem fine, and then they become menopausal. And we see that a lot. And in fact, sometimes women will come in to see me and say, gosh, I was having terrible hot flashes for the last 3 or 4 weeks, and now they're suddenly better, and I don't really know what's going on. And they say, I haven't had a period in about 45 days. And I said, well, I predict you're going to get another period right now, right? Because things are changing again. And that's why the other thing I would just say is that measuring hormone levels in the perimenopause really doesn't provide us information, because levels change day to day and we'll get different results. And it doesn't really help us guide us in therapy either. But yes, hot flashes can come and go, and ovarian function can kick back in until really you're menopausal, as defined by no menstrual bleeding for 12 months.
I had no idea. That's fascinating. Thank you to whoever asked that in the audience. Here's another one. Cheryl, maybe you can take this one. And this is a great question. Is there a special kind of healthcare provider that the questioner is asking, need, that specializes in midlife health?
Yes, I would always recommend somebody who is a NAM certified menopause provider, and that would be their designation, NCMP. And if you go on to the menopause.org, our NAM's website, you can find by city and state those who are NAM certified menopause practitioners. If you can't find one, you should, please don't just settle for any provider. At least ask if they have some expertise or training in menopause. We are trying to get OBGYN residencies to get better training. Unfortunately, about 20% of residency programs are training in menopause, which means 80% are not. So it really is so important. I wanted to throw in one last hormone that we haven't talked about at all, just because it just hasn't come up for vasomotor symptoms, but that's testosterone. Women have testosterone, and with our declining ovaries, we also are losing 50% of our circulating testosterone. And some women may notice that change. For some, it may help with hot flashes and night sweats to add it in, but for most of, but really, what we know and what we have a consensus report from various medical organizations, NAMS, the American College of OBGYN, the Endocrine Society, the International Menopause Society, is that off-label, because there are no FDA-approved testosterone options for women, another story for another day, is an effective treatment for postmenopausal women who have the loss of sexual desire. We call that hypoactive sexual desire disorder, HSDD. So it is off-label. It is not an FDA-approved treatment, but we do at least have a consensus that for those women out there who've experienced not just pain with sexual activity, which certainly can impact your desire, but who've lost that appetite for sex, for those women, they may want to consider talking to their healthcare provider, another difficult topic, about what treatment options there are for them. Certainly psychotherapy, but sometimes pharmacologic options may be helpful as well.
And I'd like to
I've always been, go ahead.
And say just one other comment, which is one of the most important things, back to the question, is that women need to use their voice. Women really need to advocate for themselves. And if you are not feeling that your particular issue is being addressed and you have tried to bring it up with your primary care provider or your OBGYN, keep looking, because there are physicians out there that are practicing in this space. Again, I absolutely agree. Go to the NAMS website, look for an NCMP provider in your area. That's a great place to start. But advocate for yourself, because again, there are practitioners out there that are doing this, and there is really help available, as you've heard. I mean, don't suffer in silence.
I can't believe that only 20% of residencies are in menopause, by the way. Do you think that's changing, Cheryl?
Yes, I do. I think NAMS is pushing that. I think the American College of OBGYN gets that, 64 million postmenopausal women, they need better training. Honestly, some of that lack of training has been because of the WHI. once hormones became demonized, the idea of menopause went completely underground, and women are invisible. Midlife women are invisible, which goes back to Lisa's point of do not be invisible. You know, use your voice and demand treatment and demand evidence-based and training in your practitioners. So I do think it's going to change. It's slow, but with, you know, programs like this, I think it's going to happen.
And I'll just say one other thing is that we have to engage primary care providers in women's health as well, because as Sheryl mentioned, particularly with GSM, the onset is later. So many of these women now are not seeing their GYNs, if at all, or very frequently, and they have other health conditions now at 60. And so they're seeing their primary care provider regularly. And, you know, this is so clear that the difference between local vaginal hormones and systemic hormones is like night and day, and primary care providers are still not knowledgeable about that and fearful even of local hormones. And because they're seeing these women, we have to engage them in education as well. And I can tell you, they're not educated in this space, and we need to do more. And it's really such an important thing for primary care providers too. We need to do a better job.
Hey, Anne, can I ask one more thing about GSM? I mentioned all the prescription treatments. I talked about, you know, estrogen pills and creams and inserts and rings, but I didn't talk about, and there's one oral approved medicine, which is a SERM, a selective estrogen modulator, that is oral. So some women don't want to be taking something in their vagina; they're uncomfortable, or for variety of reasons. So there is also one oral medicine, and I wanted to mention that. I also want to mention pelvic floor physical therapy for those women who've been struggling with GSM. We know that regular sexual activity, using stretching, you know, sex is great. It's good for your, you know, mental health, physical health. It's good for GSM. Even if you don't have a partner, you know, self-stimulation or using dilators can be very helpful. But for many women who haven't been sexually active, they may need some pelvic floor physical therapy, and that's really a helpful option as well.
So helpful, thank you. There's a number of questions now, of course, about WHI, which we could spend another hour talking about. A lot of questions about how can we correct this misperception? How can we sort of, when is the media going to start addressing it correctly? I mean, my own answer to that is this is the beginning. Here we are talking about it, right? And then there was another question about, can men's magazines cover menopause? We're getting to the end of our time, but I'm just thinking about if you all, other than just speaking to women the way that you are right now and talking to your patients and discussing these things at Miriam's conferences. Oh my goodness. The age of Zoom. What would you, is there some sort of bigger, larger picture thing that the medical community can do or the media community can do to change this perception of hormones out there? Lisa, could you start?
Yeah, I mean, so I think, as we've said already, I mean, from my standpoint, there's two places to go, which is provider education. We have to figure a way to educate OBGYN residents and OBGYN providers that are already practicing, and primary care providers in training and after they're out. Because again, the misinformation is really the barrier, right? The other thing is just even education or understanding. Doctors do not like to do things that they don't know well. Right? So if they don't think they know the data, they haven't been trained in how to examine the vulvovaginal tissue, they don't know anything about this, they are not going to ask and they're not going to do anything. We have to really educate them. But the other piece is really educating consumers and women, really. And from my standpoint, it's really trying to get the message out there about, you know, what's evidence-based medicine? What are the published guidelines that are really out there? Because there is so much misinformation out there, and you know, it's being driven for lots of reasons, but sorting out the fact from the fiction is very, very hard. And so I think organizations like Healthy Women, which I'm so proud to be involved with, does an amazing job, again, of helping women with evidence-based information. And it's a great resource for women because you have to make smart decisions. And we need to keep educating women, again, so they can be better consumers.
Cheryl, what would you say? Sorry, I'm muting because my dog is still going crazy out there. What would you
Okay,
say is
well,
a bigger
I think
picture
that
solution?
dogs are very good for mental health. But I completely agree with what Lisa said. Actually, NAMS and Healthy Women has been partnering to try and push the concept of advocacy. I think it's so important that women have a voice, but also that we're recognized and have, fair treatment. I mean, if you think about hormone therapy and prescription coverage, that's also an issue that not all insurance companies will cover, whether it's local therapies or systemic therapies. It's not all, it's not all covered. For example, until recently, they assumed that treatment of vaginal atrophy was a sexual treatment because the main symptom was pain with sexual activity, but it's not. It is a symptom of menopause that happens to be pain with sexual activity. So, insurance companies will say, well, we don't cover Viagra, so why would we cover, local estrogen? And that just is, crazy making. So we need to be better about advocacy to get fair treatments and women to, have equal voice at this.
We've spent a lot of time talking about the sort of, pharmaceutical or medical treatments for menopause. And I know that there are, not a lot of studies done about or evidence about sort of herbs and those kinds of nutritional supplements. But are there lifestyle changes in diet and any other like exercise or just living our daily lives that will help with the symptoms of menopause?
Right. So
Lisa, why don't you start?
So for sure. I mean, I will tell you that I really focus a lot on lifestyle modification and healthy lifestyle for all kinds of reasons, not just for menopause symptoms. One of the big things that women may or may not know is, alcohol can be a real trigger of vasomotor symptoms, for example, never mind disrupting sleep, but we have the increased breast cancer risk with increased alcohol consumption. And again, that's something that women don't often hear or really acknowledge, right? So they're scared of hormones because of breast cancer risk, but they're having 2 or 3 glasses of wine a night, and that's a big risk factor. But to your point, lifestyle in terms of eating a healthy diet, maintaining your ideal body weight, exercising regularly, stress management, getting enough sleep, those are all very helpful for managing menopause symptoms. But again, many women are suffering so much that that's not really adequate. And again, that's when we get into the prescription and non-prescription or hormonal and non-hormonal options. To your point about supplements, we don't have the level of science about lots of these supplements. And like I have concerns about compounded products, there's less regulation of supplements. And so manufacturing and dosing and purity and what's actually in them is not as consistent. And so it's harder for me as a clinician to necessarily, at least today, with limited data and not such clarity about manufacturing and production, to really push a lot of supplements. But women try them. We know that women are trying them. And again, they get a lot of marketing about them. And it's an area that I do hope that there's I know that there's also things coming up the pipeline in this, and that we will have science advancing in this area as well.
Great.
Lisa said it all, but there's some evidence about vitamin D. Not too much of a good thing is not a good thing. So people often assume if as little is good, a lot is better, and that's not true. But my concern about supplements and non-evidence-based over-the-counter is that women think that if it's over-the-counter, it's safe, and that's absolutely not true. And B, they're spending a lot of money. And so, there are unscrupulous marketers out there who would love to take all your money, which leaves you very little for, healthcare that you really need. So I worry about that. So I think to Lisa's point, certainly lifestyle, I'm really bummed about the, alcohol thing, but because I love my glass of red wine on occasion. But mental health issues, certainly, getting treatment. Psychotherapy is a non-hormonal treatment for mood changes. And we know that many women at perimenopause, not necessarily postmenopause, and last week's session really talked about this so well, can have mood changes with those hormonal shifts. Weight gain, we often assume that weight gain is either due to hormones or not due to hormones, but at midlife, you know, as our metabolism shifts, you know, if we can up our exercise, it's good for our mental health and will help keep our weight stable, and certainly eating a healthy diet. I can't argue with that.
So many more questions as always. I hope to that we can all do this again soon. There are, and would like to remind everyone that there are 3 more sessions. I'm sort of looking on my computer screen. I can't remember exactly what they're all on. You all know, but there's one I know on pelvic health, and there is one devoted, I think, exclusively to sex and pleasure at this age as well. And I'm forgetting what there's a 3rd one in there. And I also want to remind everyone to take a survey that you'll be getting. I think that you sort of pops up on your screen when you leave here. I'm not sure. I'm not the tech person involved, but please take that survey. I want to ask you each to just sort of, if you can think of not an overarching solution for everything, but just maybe a takeaway for us to leave, maybe something you wish everyone knew, or that you wish that you knew, or something you know for sure about this phase of life. Lisa, could you start?
So don't be terrified of menopause, because there's good things that happen postmenopausal as well. But I would encourage women just really to use their voice and advocate for themselves, and not to suffer in silence, and to not believe that all hormones are bad. That the data really, for many women, that's going to be a great treatment option for you, and find the right provider who can really talk to you about the data and risk benefits in a way that makes sense.
Thank you. Sheryl.
Margaret Mead, a long time ago, talked about the concept of menopausal zest. And so I want to also support the idea that, you know, as we are going to live over a 1/3 of our lives, now more like half of our lives postmenopausally, we want to do it with zest and vitality, and there's no reason not to. So the idea that we're, you know, sort of old and you know, useless is totally wrong. The whole idea of menopause is to free women up from the idea of worrying about an unplanned pregnancy or raising children. And now it's our time to go out there and be the CEO of a company, or which, you know, Lisa now is, or the editor, or, you know, running a new company, which you all are. So it's our time. So let's use it wisely.
I love that. I cannot think of a better way to leave us this session. Thank you so much for clearing up so many misconceptions and for really educating us all. I do have now someone has helpfully told me exactly what we're looking for next week and beyond. Session 4 will be about pelvic health. That's next Wednesday. Session 5 is disease risk in menopause, what you need to know to keep your whole body healthy. And session 6, which is November 18th, is the sex talk. Is it possible to have an exciting sex life when we hit menopause? Hint, the answer is yes. And I can't think of another best parting word for everyone. Enjoy the rest of your day and month. And thank you so much to Sheryl and Lisa and Healthy Women, and to Beth.
Thank you.
Thank you.
Thank you.
Thanks, everyone.